Okay.
See, I see Doug is.
I believe Doug is online, and I think Hung was gonna come online as well.
He's gonna be
today.
online. Yeah. Okay. Are you ready?
Yep. I think so.
Okay, great. Well, good morning. Here we are again for the what about the fourth or so? Yeah, board meeting, or maybe even more. Feels like we get together a lot. Anyway, I want to welcome folks, and what I'd like to do first is some introductions. Mary Ann Lindblad, I chair the board, and we could go around the folks in the room. Greg Gibson is new to us today, and we'd like Greg to maybe Greg, you can start out a little introduction and tell us a little bit about yourself.
Yeah, so my name is Greg Gibson. Kind of born here in the Northwest in Portland, but grew up in Olympia actually, so it's kind of fun to have an opportunity and an excuse to come back to the area. But I'm in Seattle now. Most of my training, went to school up in Western Washington and ended up going to pharmacy school. Came back to the area after that from California. Did some residency at University of Washington Medical Center. Have since stayed, worked as a pharmacist, kind of focused in critical care. Did some cardiology work and some other things, but mainly in hospital pharmacy for about 10 years. And then about a year and a half ago, switched over to a different role within UW Medicine. Now I'm a drug policy and utilization pharmacist there. A lot of my work now is looking at drug costs, drug use, policies associated with all sorts of medication-related issues. Drug safety is a big aspect of my position there. I also play a role in our pharmacy residency program, so I do mentor a lot of learners, people going through the program, gaining skills after they've completed their formal pharmacist training. Yeah, now I'm here to play a role in this, so I'm happy to be here. And thanks for bringing me to the board.
What do you do for fun?
Oh, what do I do for fun? Yeah, well, I've got 2 small children, so a lot of things involve chasing children around, going to the park, monkey bars, so a lot of that stuff. But I used to ski. Kind of cycling was a lot of fun for me. So,
well, welcome.
Yeah, thank you.
Great to have our final member.
Eileen Cody, I'm a nurse first, nurse first, and former state representative.
And we've got a couple of the members that are online. Doug?
Hi, everyone. Doug Barthold, board member. I'm a health economist and research associate professor in the UW School of Pharmacy and the Comparative Health Outcomes Policy and Economics Institute. Thanks.
Yeah, and is Hung on? I don't see him. We may have him introduce when he arrives. And so then I'd like to just have the staff go ahead and introduce themselves here in the room.
Yeah, Mike Newishwander, the director for the Prescription Drug Affordability Board here with HCA.
I'm Ryan Pistrosi. I'm the Assistant Chief Pharmacy Officer here at the Healthcare Authority.
Michael Tunick, Assistant Attorney General and Legal Counsel to the board.
And Simon Borman, Policy Analyst on the UW team.
And then the staff that are online. Little print, I can't. Ellie, can we start with you? Well,
yes. Oh, can you hear me?
Yes.
Okay. Hey, I'm Kelly, and I'm the PDAB data analyst.
Yes, it's there.
Marina.
Hello, this is Marina Suzuki. I'm Health Economics Research Manager, so I'll be helping with the affordability review.
Well, that might make it easier to see things. Feel a little better.
Thank you.
Thanks.
Okay, Jinping, are you on?
Yes, this is Jinpei. I'm the Cost and Quality Analytics Manager in HCA in the data team.
Great, thank you. I think Donna texted me. She'll be on here a little bit later. So
great.
I think Hang is also online, but he's saying he cannot speak. I don't know if he has the panelist access or not.
Okay,
Get Simon here to see if we can,
we can get him.
let's see.
Look on the attendees.
Oh, attendees.
Voting him to panelists.
We'll get this here.
There we go.
All right. Is he on?
Yay, thank
Go
you.
ahead.
Hi, everyone.
Welcome.
Sorry, I joined on the website Zoom link, and I didn't have one to the panel.
Great. Well, why don't we go ahead and get started? So Mike, I'm gonna turn it over to you.
Great. Pull up my list of stuff to talk about. So we had our first advisory board meeting last month, where we were able to begin introducing the advisory board basically to the PDAB and the legislation and their role. I know some of the advisory board members have already been following our PDAB work here, so for some of them it's a little bit of a review, but our first meeting was more kind of like we did with our first board meeting, more administrative in nature and just trying to get the foundation set up for what we'll be doing. So we'll talk a little bit more about kind of the next steps for the advisory board here later at the end of this meeting. But so that was good to have that up and running. We also have had the opportunity to answer some questions from some of our partners in industry and refine some of the work that we've been doing, which has been great. And so with that, we're doing some updates to our draft eligible drug list and tweaking a few of the ways we do some of the calculations to help clarify some things. So that was, we've had some really fruitful and useful meetings here in the past couple of weeks with that. And so with that, we'll be updating that list and some of the data in the coming days, and then uploading that data, that revised data, into the dashboard as well. So once we get that finalized, we'll share that with everyone. And along with that, with the dashboard, we're very, very close to having that completed here. We're still going through, again, some final tweaking and inputting of the data, as well as the final steps of the approval process to get it shared here with the board and the advisory group. So the final version is still going through that process, but as soon as we get that done, we will share that link. Today, Kelly will be talking about the methodology and kind of the selection process of what's making the dashboard work. And she'll have some additional data to share in terms of the weighting and rankings and everything that the board submitted, as well as how that shapes our top 25 list of drugs that we'll be able to look at. So in the coming days, very soon, look for that. And then again, I'll talk later about how we will use that and present it to the advisory board as well to help give us input for our next meeting here in January in terms of looking at which drugs we want to select. And then just kind of a follow-up public comment, we had Sarah Lanford from the Policy and Advocacy Association for Clinical Oncology asking a question. I just wanted to make sure on one of the public comments that we followed up in terms of how we work with physician-administered drugs. So Ryan, you want to share?
Yeah, so based off of the statute for how the PDAB identifies eligible drugs for review, the criteria is really, around how the drugs are dispensed. So if a drug is dispensed from a retail, specialty, or mail order pharmacy, it is eligible to be counted under our drug list. And when we think about physician-administered drugs, we typically don't think of them as being available through a pharmacy, but because a lot of these physician-administered drugs are in fact available through pharmacies, they are being counted for the drug list. And I think a good example to think about is the long-acting injectable buprenorphine medication, so Sublocade and Brixadi. There is a REMS program in place that makes it a requirement for any of these providers to get these medications to make sure it never ends up in the hand of the patient. but these drugs are in fact available through specialty pharmacies. So even though this medication can never be dispensed to a patient and it has to always be administered by a physician, it does meet the eligibility because it is available through specialty pharmacies. The same thing is true for limited distribution pharmacies, because these pharmacies are dispensing medications, where the pharmacist is labeling it with the patient's name and it's leaving that pharmacy. Even if it's going to a physician's office for them to administer it, it still meets the statutory definition for being eligible on the drug list. So even though we don't typically think of the physician administered drugs as drugs under the purview of this, because they are available through these specialty pharmacies, they are ending up on our eligible drug list. So just to keep in mind that was a comment that we had received, seeking questions about why these drugs had appeared on the list. This is, the reason why they still are on the list.
Great. Thank you. Just kind of want to follow up. We really do appreciate the comment, public comment that we receive. We do look at it, and it gives us an opportunity to dig in and answer some of these important questions, as well as helps refine our process. So we greatly appreciate that, and we'll follow up with that message, with written explanation as well, just to make sure we close the loop on that. So. With that, I think those were my big topics for the director update here.
Right. So next topic. So the board will be voting on updates to the eligible drug list identification policy, and Mike, take it away.
Yeah, so we've been working on this policy over the summer. Again, we had some comments from industry, which allowed us to go back and tweak some of the language. But basically, this is the policy that we use to put together that initial drug list, which then we will pull from to help create our dashboard. So I know we've talked about this and looked at it in the last couple of board meetings and some of the changes. So I think nothing really new this go around. So I think we're ready to vote and go for it.
So let's go ahead and vote, excuse me, on the eligible prescription drug policy. So for all those, I need a motion. Thank you. That was your legislative.
I move that we endorse the policy as written.
Do I have a second?
Second.
Accept. So it's been moved and seconded to go ahead and endorse the policy as written. All in favor?
Aye.
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 Any opposed? All right, been moved, seconded, voted, so policy covered. It's all your experience.
Those motions. Yeah. I've had motion sickness before.
All right, well, that's that. Okay, so now again, turn it over to Mike. We're going to be reviewing the drug selection policy.
Yeah, and so with this one, basically, this is going over what we've been discussing at the last meeting. This is trying to write it down and put it into, a standardized written format of what we're doing. And Kelly will go through a lot more of this today during her presentation. So this is basically our first draft to take a look at it, and introduction to how going over the different criteria that we talked about in terms of the 6 criteria that the board wanted to look at as we're creating this dashboard to create the drug selection policy, the weighting, how the weighting works, incorporating the weighting votes or numbers for the different categories at the board selected. And then again, Kelly will walk through this more. So this is more just kind of the initial look, take a look at it, peruse through it until the next board meeting. And then if you have questions or other comments or problems with it, then we can address it there. So more just the introduction to this new policy and the ranking and how we did that. So
is the plan then to take a vote on it next time?
Yeah, as long as, again, everyone's happy with it, and we all understand it, and we're all good with it. And then, of course, give time for industry and anyone else to have some public comment on it. Help us if they think that we've missed anything.
So,
Any question?
so on the ranking, I see that we had a tie on CD. That, and then this. Are we gonna have to figure out which comes first, the chicken?
And I think Kelly will walk
Okay.
through the whole how the ties and all that. At the end of the day, with this ranking, it's not so much super important that what is first and second. I think the key is trying to narrow down a huge list to a
Right.
smaller list, and then as we look at the top, handful of those drugs, then the board members can look and decide, hey, these drugs are, look like they're the most expensive. These ones have the most utilization. These drugs have, generics, which might affect that. Additionally, Kelly has put together a list of what states or what drugs other states have reviewed. So if we say, okay, well, Colorado's already looked at Enbrel, do we want to do a review that another state's done? Yes or no? If maybe yes, because we think it'd add more weight to the review, or no, let's not duplicate work that someone else has already done. So that's up for the board to decide, but.
Well, but don't we have to at least just review the review if we were gonna do we're a couple years from this, but to do the, like the price counter?
Yeah, the upper payment limits.
Yeah, upper payment.
Yeah, so if you wanna do an upper payment limit on a specific drug, then we need to do a drug review on it first.
Even if another state's done it.
Yeah.
Yeah.
So, and so, yeah, that's, I think, some of the things that the board can consider. But, yeah, Kelly will kind of walk us through all of that here in a little bit. So anyways, for your information, take a look at it, read it, and poke any holes in it. That's what it's here for here is to help us make it a better work product. Okay, any questions on that policy?
All right, so Mike again, ready for next one?
Yeah, so then that takes us, we're done with kind of the paperwork policies. Now we're starting to get into, we'll do the initial kind of review of the dashboard here with Kelly and Jinping or the strategy behind that. But also another conversation that we need to start having here soon is how many drugs do we want to review? So the legislation, outlines that we can do quite a number of drugs here on this initial go around, should we so desire, but we don't have to do. Was it signed 24? I believe.
I think up to 25.
Yeah, or up to 25. 24, 25.
24. Yep, 24.
Okay,
sorry.
No worries.
We're looking at something else.
However, I don't know that we necessarily have the capacity at this point to do 24. So I kind of opening that up to the board, maybe we don't have to make a firm decision today, but I think in the next meeting or so, we'll need to kind of decide on that. And I think Doug has something.
Thanks, guys. Yeah, just for determining the number of affordability reviews that we want to do, I think for us to have any sense of the right number, we need to know the time span over which we have to do them, and how long we think it takes to do one. Because obviously that feasibility constraint is, I think, going to be the most important one. Obviously, like you said, I don't think we can do 24, and so can we do 2? Can we do 6? Like, I don't know, can we do 10? I have no idea. And so do you guys have any sense of what we do have capacity for?
Well, and so with that, we do have Marina on, and hold on. I think there's some questions on document access, Simon. As we've never done a drug review before, a lot of this would be a little bit of guesswork. And I don't know, Marina, do you have some initial thoughts as She's kind of leading the charge here on developing our drug review. I've stepped away.
Oh, sorry, I was muted. Yes, so the plan is we are developing the stakeholder information form. So we'll collect both like narratives and also some data from all our stakeholders, including manufacturers, patients, and also the experts of the subject matters. And hopefully we'll be reaching out to the wholesalers also. And then once we collect everything, we'll summarize the information, and we'll keep the confidential or proprietary information for the closed session. But we can share pretty much everything with the board members, and cost effectiveness analysis, budget impact analysis, that will be also collected as well. Whatever is existing from the manufacturer side as well. Yeah, so outline was shared at the last board meeting, but we are still developing all the forms. So we can still make tweaks if there are any additional requests. But yeah, the plan is that we collect information first from our stakeholders. We'll do an internal review, validation, and summarize, and then we'll present to the board members.
Mike, would we be able to ask other boards who have already done it, just an estimate on how long it's taking? And then are we able to get like a preliminary list, like say the top 24 for us to take a look at? I know the information might be difficult to get, as Marina has said. But if there's a preliminary list, then we may know like, okay, there's 10 that really stood out. And then, maybe we decide on the 10. So I don't know how difficult that would be.
Yeah, and we do have a preliminary list here. And Kelly, I believe we'll be talking about that here in a little bit. So we can kind of take a look at that. Again, once we get the dashboard finalized, then there will be a lot more data associated with that list, and you can kind of compare and contrast drugs, which will be really nice. But yes, we'll talk about that preliminary list, and yes, we definitely can follow up with the other boards on what's happened with them. I know some other states started and found that the drug reviews were a little more complicated than they had anticipated, so then they had to kind of stop and restart. And so I know there has been some difficulties with some states on that, but yeah, Colorado has completed their 5 drug reviews, and I can follow up on the exact timing of how long each of those took.
Are they the one state that's completed some numbers, some number?
Yeah, Maryland has selected some drugs for review. I don't believe those reviews are done yet. Those have been out and pending for a pretty decent time, right? And so yeah, Colorado's the first one that's actually gone through and done it. And I believe Oregon's restarted some of their different reviews as well. So every state's kind of in a little bit of a different spot with that.
And just to follow up on the time span, do we have a date by which we need to be done with however many we do?
So there is no like required, like you have to do X by every or a single day. It says you can do up to 24 per year. As this because we're still developing the program and we haven't finalized our methodologies for this stuff yet. This first year will be a little bit weird, as we're still building the airplane as we fly it. But then in subsequent years, once we, and so kind of my vision is, I guess, let's get through a few, see how long, see what it takes to do it. Start small, and then once we have a better idea of like, it gives us a chance to work the kinks out. And then we can go and in the following year have a whole lot better idea of, okay, this is where we had problems last time. This is the data. Here's how long it takes to collect it. Based on our staff capacity, then we can do, X, Y, Z and kind of extrapolate out from there. But as this is all very new to kind of everybody across this country. I don't have a solid answer for some of this stuff yet.
Mike, do we have any obligation for a report or anything for the legislature for 2025?
So we do annual reports of our updates on our program, and it's due in December of every year. And so with that, we tell them what we've done, and the
We
drug.
have no specific expectation
Yeah,
at this point.
Yeah.
But the drug has to, once we do the review, then the legislature has to have a session before there'd be an upper payment level. So it should be kind of, I would expect that we should time it to get reviews done for the year by December so that.
Yeah, and I think once we kind of get the system going, we can do that. But again, upper payment limits aren't even until 2027. So it actually works out really well right now in terms of timing, giving us this time to develop the program, develop these drug reviews, and then once we kind of got a groove going, then we can set that cadence so it appropriately times up with any approvals that the legislature has to do.
I know they'll be looking for.
So I guess how important is it to set like a number right now? Can we do 2 of them and just kind of time it and see how it goes and use that to reassess our process, or do we kind of have to pick?
So there's nothing that's saying you have to do X. And so I think, given where we're at, giving ourselves as much flexibility as possible. I'm kind of a fan of, start small, and if it's a lot easier than you thought, oh, great, we can add a couple more. Is kind of my philosophy. I guess what I would recommend against is, hey, let's try and pound out 20 this year, and then realize, holy smokes, we just bit off way more than we can chew. Now we're in trouble.
Yeah, and I think one of the things we'll need to consider is that for the affordability review phase, we'll be working with different drug manufacturers, and some may be quicker to respond than others. And so by having, a few that run parallel to each other, we can then say, oh, we got this data back earlier, we can then start processing this affordability review. But we had questions with this other manufacturer because the data we received from them may not be lining up with the other data that we have, resources that they're making. It's more conversation. So I think, having a few that run parallel to each other gives us the understanding of how do we, work with multiple drugs at the same time.
Yeah.
So Mike, are you hoping to get a firm number or just
I think right now it's just more of this discussion of, I think Doug has some really good questions. We can go back and look at that. If there's any other questions that the board has, toss them to me now. We can make sure we're putting this all on the docket. And I think this is just more the initial, let's start thinking about this and again, answering these questions that you have in terms of, what are expectations? What are the requirements? Do we have to pick X amount of drugs? Do we, can we switch? Can we add more later? And so I think just having this initial discussion to grease the skids and have the board members come back next time saying, okay, I think we, based on the information that we have, based on the questions you've answered, I think I want to do X. And you guys can decide amongst yourself, working up or down of what do we think is appropriate and realistic. So any other? Yep.
This is Marina. So for choosing the medications for review, I think it's helpful if it's a prioritized list instead of we pick 5 drugs for this year. We have maybe like top 5, top 10 prioritized list, and we'll start from number 1. We'll start reaching out and see how long it takes to get all the data and information. So that way we know which one board members are most interested in, rather than having just a bullet point list. If it's prioritized, I think it's helpful for us to know like where to reach out first. Yeah.
I mean, that makes sense to me. You know, maybe we end up with a list of 10 and then prioritize and start from that number one and work our way down and then get a sense of what that work looks like.
Okay.
I like that too.
Yeah, and then I think maybe we can kind of, have that list, start with our top ones, and then depending on the timeframes that we have and when the next, list of drugs come out, we kind of get where we get, and then we can start over. And if the next list is very similar, maybe use that as a starting point to help pick where we're going from there.
What we'd be really happy about is if they're on the top 10, but we didn't get to them, if they lowered their prices so they weren't on the list the next
They
time.
took themselves off.
That's right. It's always a possibility.
Yeah.
Oh,
Yeah.
Pollyanna.
Well, you never know. Never know. Have lots of people here listening, and maybe we can come to an accord. Okay. Any other questions? Oh, Doug.
Yeah, just on the sort of the prioritization. The one I really like that approach of, choose if we have our ranking and we start at the top and we do however many we can do, that's great. The one thing that I would be concerned about with that is that like if I'm guessing is gonna be varying degrees of difficulty with the different drugs, and so I don't want us to get hung up on like, let's say our second one is really hard to do and we can't get any data and we're waiting around forever. I don't want to like that to delay the third. So I don't know if we're gonna be able to do them in parallel to each other, and sort of start the next one as we're waiting for the whatever the manufacturer from the second one to give us the data we want. Or as we're accumulating evidence about them. I don't know. Does that make sense? Do you think we'll be able to do them in parallel?
Yeah. I think doing a couple at a time within parallel, especially to start out, because I think there is going to be a degree of hurry up and wait as you put out a request for data and you're waiting for someone to respond. And because there is some data, as Marina was discussing during our last presentation, that we can pull from APCD or FTB or any of our other internal sources that can help inform certain parts of our report. ICER additionally might have data that we could use, or other external partners. So with that, if there's places where we can pull data or use data that exists, that's a lot faster. But then there's going to be parts where it's the hurry up and wait. We've got to have people respond. And then if there's questions, then you've got to go back and forth. So I think if there is I think the idea would be to have a couple, chickens in the pots, so to speak, at the same time.
You do a data call for like the first several.
3 or 4 or something. Yeah.
And so kind of see where we go, and depending, again, as Ryan was talking about, on something that maybe moves a little faster, that report can get done faster. So, but again, I think that's the vision, and we'll have to kind of see how some of that plays out when we actually are doing it. So it all sounds easy on paper.
Yeah, just to give a more like realistic expectations, ICER usually takes 7-9 months to review one drug. Colorado, similar, I think for the first drug, they took like 9 months. So it's not like we request all the information for this month and then we'll get everything by the next board meeting. So I think it will be a long process to collect everything and analyze and summarize the information. So so I like the idea to reach out to multiple drug companies, patient groups in parallel, and see how it goes.
Is there a time limit for how long the drug companies have to get back to us?
Yeah, according to the legislation, I want to say it was 30 days.
And if they don't, then there's a fine.
Yeah.
And I think there's some teeth to it.
Yeah, and the fine varies depending on the, the reason for the delay and stuff like that. So
that's all outlined in the WAC.
And so, yeah, and that's a whole nother process in and of itself, which could add more time, you know, should we have to go down that route, so. Okay, any other questions? Doug, Hung?
Anything?
Okay. I think that's some good food for thought, and we'll follow up with that with some emails individually here on that, and then during our one-on-ones we can kind of dig in a little bit more deeply on that as well. So, and then we can also get thoughts and comments and advice from the advisory board as well.
That's a good idea, particularly on this one.
Yeah.
So, so we ready to? Yiping and Kelly talk about the data dashboard?
I think so.
All right.
Okay, so last board meeting, we talked about which data measures the board was interested in using to select prescription drugs for affordability review. So today I'm going to go over how the board used those data measures to create a short list of 25 prescription drugs for affordability review, and I'll also be showing the list at the end. So in this presentation, I'll go over again what the board is required to consider when selecting prescription drugs for affordability review. Then I'll review again the data measures that the board chose to select prescription drugs for affordability review. And then I'll talk about the methodology we used to create our short list of 25 candidate drugs for affordability review. And then finally, as always, we will have some discussion at the end, but you don't have to hold your questions or discussion until the end. Feel free to interrupt me if you want to ask questions or discuss something, or you want me to go back to another slide. So this is a reminder of where we are in the affordability review process. So right now we're at the selecting drugs for affordability review stage. Okay, so a reminder before we jump into the proposed data measures, the bill says that we must look at 3 data measures, and that's the class of prescription drugs and availability of therapeutic equivalents, input from relevant advisory groups, and the average patient's out-of-pocket cost for the drug. And then also the board can choose up to 24 drugs a year to review. All right, so let's quickly review the data measures that the board wanted to look at when selecting prescription drugs for affordability review. So the board would look at those 3 required measures from the bill that I showed just now, which I color-coded in blue throughout the presentation, just so it's clear which data measures are from the bill and which were proposed. And the 4 data measures that the board proposed are shown in dark green, which I'll color-code in dark green throughout the presentation. And then also you'll notice an icon are 4 of the measures, signifying that those are quantitative data measures or data measures that can be measured, counted, or expressed as a number. And this will become important in our process later as you'll see in the coming slides. And if you need a refresher on what each data measure is, the definitions are in the appendix of this presentation. Okay, with that out of the way, let's jump into how we created the short list of drugs for affordability review. So a big question is, how do you use the information in the data measures together to choose prescription drugs for affordability review? So our methodology was to first rank and weight the 4 quantifiable, if you remember those 4 quantifiable data measures with the icons from the previous slide. To calculate a weighted rank for each prescription drug. Then the top 25 prescription drugs with the lowest weighted rank formed a short list of drugs from the board to choose from for affordability review. And then finally, the board will review the weighted rank in all the data measures, both quantifiable and non-quantifiable together to select prescription drugs from that short list for affordability review. And don't worry if you did not understand a lot of this, I'll be explaining each step in detail in the coming slides. In our methodology was to rank and weight the 4 quantifiable data measures. So to do this, the board participated in a prioritization exercise to determine how important they thought each data measure was when selecting prescription drugs for affordability review. So while the board was doing that, on the data staff side, we sorted each data measure in descending order and assigned rankings. And I'll show an example of this later, so don't worry if you don't understand this right now. And then once we got the results back from the board, we computed the weighted rank for each drug by summing the rank of each data measure multiplied by its corresponding weight that was created by the prioritization exercise from the board. And then I'll show an example later, so just hang tight if you are having trouble following at this point. Okay, so more about the prioritization exercise and how did it result in weights being created for each data measure. So each board member was given 20 points, which totals to 100 points across 5 board members. The board members were told to allocate their 20 points between the 4 quantitative data measures, and that the more points they allocate to a data measure, the more important it is to them. And then once they gave us the results, we summed the allocated points for each data measure to create the weight for that data measure. So this is an example of how a board member might use their 20 points among the 4 quantitative data measures. So in this example, the total number of people using the drug was most important to this example board member, so they assigned it 10 points. However, the other data measures were also kind of important to them, so nothing was assigned 0, but total out-of-pocket cost was the least important to them because it was only assigned 2 points. Okay, so here are the actual results of the board's prioritization exercise, and then you'll see that I highlighted the weights that were created as a result of this at the bottom. And the weights show that the total out-of-pocket cost was the overall most important data measure to the board when selecting prescription drugs for affordability review and will be weighed the most heavily out of the 3 measures. And then similarly, total number of people using the drug was the least important to the board and will be weighed the least. And this is a visual representation of the overall distribution of points versus how each individual board member distributed their points. So you'll see that some board members thought that some data measures were not important at all and gave them 0 points, while some board members thought that all the data measures had some kind of importance.
Yeah, Doug, I know you had some questions in terms of the point allocation. Did you want to talk about some of that?
Yeah, well, I guess I don't know if we want to let Kelly finish first, but I was thinking it might be helpful just for the board members to discuss sort of why they voted as they did. So that way we can sort of understand why we care more about one or the other, and then that might help us sort of I don't know if we're going to end up changing these votes or not, but just to kind of justify what we're ranking, this overall ranking that we're going to have.
Kelly, would you prefer that now or at the end?
I don't mind either way.
Maybe we can walk through and then do it at the end. I just wanted to make sure, Doug, since we talked about that.
Yep, appreciate that. That's fine. Doing it later is fine.
Okay.
All right. So we'll go back to this later. Okay, and then as I mentioned, while the board was doing their prioritization exercise, I sorted each quantitative data measure in descending order and assigned rankings. So here is an example of how that was done. So for example, we sorted the average out-of-pocket cost in descending order, and the drug with the highest average out-of-pocket cost got assigned a rank of 1. The drug with the second highest average out-of-pocket cost was assigned a rank of 2 and so on, and we did the same across the other 3 data measures. So unless the prescription drug topped every data measure across the board, they'll have different rankings for different data measures. So for example, for drug A here, they ranked first in average out-of-pocket costs, but ranked in various other positions for the other 3 data measures. So what if there are tied rankings, or in other words, what if 2 or more drugs share, say, the same total paid amount? How would the rankings be assigned then? So to break tied rankings, we use the average ranking method. So for example, here you see that drugs C and D both have a total paid amount of $12 and are ranked in position 3 and 4, when really one shouldn't be ranked higher than the other because they have the same total paid amount. So using the average ranking method to break the tie, they'll both be assigned the rank of the average of their rankings. So here they're ranked in positions 3 and 4. So to compute the average of their rankings, it would be 3 plus 4, which is 7, divided by 2 because there are 2 drugs that are tied. So that means 7 divided by 2, which is 3.5. So then they are both assigned the ranking of 3.5. Okay, so putting together the weights that we created from the board's prioritization exercise and with the ranking of each data measure, we can calculate the weighted rank for each drug with this formula. So for each drug, the rank of each data measure will be multiplied by the weight of each data measure will be multiplied by their corresponding rank. And so if you put in the weights that we have so far, the weighted rank is, again, the rank of each data measure multiplied by those weights that I showed you a few slides earlier from the board's prioritization exercise. And so if we apply this back to our previous example, so for drug A, the rank of 1 for average out-of-pocket cost will be multiplied by the average out-of-pocket cost weight, and the total out-of-pocket cost rank of 2 for that drug will be multiplied by the total out-of-pocket cost weight, and so forth. And then you can see like the rest of the multiplication that will happen here, and then the sum of all of that would be the weighted rank. So applying this to real drug data, I'll demonstrate this with Xtandi, which is a prescription drug used in the treatment of prostate cancer. So you'll see that for each of the 4 data measures, it has a different ranking, and it happened to rank the highest out of all of them in total out-of-pocket costs, where it had the second highest total out-of-pocket costs out of all the eligible drugs for review. So plugging these numbers into our weighted rank formula, we have that the weighted rank for this drug is 6.63. And this is also the drug that topped our list of 25, our short list. Okay, so this is our preliminary short list of the top 25 prescription drugs based on their weighted rank, which I just showed you like an example of in the previous slide. And so these are the 25 that would choose drugs to conduct affordability reviews on. And just to clarify, the rank here that I showed is based on their position in the short list, not the weighted rank. So I don't know if we want to look at this for a second before we move on.
I mean, it's all specialty drugs. All of it, except for a few. So you're talking about the 3% of the population or a health plan lives, 3 to 5% would be on these drugs. The rest would not be. So it's something to keep in mind.
Could you just repeat that?
Yeah, what are you saying, Han? I didn't get it.
What I'm saying is when you look at this list, the majority of these are specialty drugs. And so on average, if you look at a health plan, there's only about 3 to 5% of the total lives would be on these drugs. So you're basically seeing that only 5% of the population would be on this list.
Yeah, and also I think it also corresponds with how total number of people using the drug was also weighted the lowest. So that probably also plays in, that's also probably a reason why the drugs are this way in the list.
And this is Ryan. So Hung, yeah, you're right. And I think one of the reasons why we see different boards in different states be able to review other drugs is that our state, Washington, does have the highest threshold and cost per year. So we are at $60,000 per year or higher, whereas other states like Colorado are only 30,000. So if you do look at the eligible drug list between us and Maryland, Colorado, and other states, they do have some more of those non-specialty traditional drugs that you see, like with the HIV medications, diabetes medications, things like that. So that I think plays into your observation that our list is dominated by specialty drugs.
I just had a question. So the list, just looking at the list, are we going to break these down by, it looks like NDCs? Is that how we're going to rank them? We're going to cluster them together for like, and this is like per tablet size, per, Enbrel's on here like 3 or 4 times for the different administration methodologies that are set up and patented. Is there a plan to pool these together, or we're going to get them all separately?
I think that's a decision for the board to debate. So right now, yes, these are at the NDC level, but if you see, Enbrel up there and you know that Enbrel's on there a few different times, you could say, let's do one of Enbrel together because that affordability review is going to be for that drug, right? So you're going to be looking at therapeutic alternatives. Well, the therapeutic alternatives for all 3 of those Enbrel NDCs are going to be the other cytokine and CAMs. Off-label uses, right? That they're going to all have the same off-label uses. So I think that makes sense for you to consider those together. So even though that they have individual lines here on the list, or when you're selecting an affordability review, you can say, let's look at Enbrel all together.
I think Doug has a question, comment.
Yeah. Thanks. This is really helpful. So I just have a question for Kelly. I'm not sure if I understood this correctly. You said this is a ranking by the shortlist ranking and not by the weighted rank. Did I hear that correctly?
No, the top 25 is by the weighted rank. I just wanted to clarify that the rank that I'm showing here on the left is not their weighted rank. I just put it like showing this is the top 25.
Gotcha. Okay, I just want to clarify that. And then yeah, I definitely agree that pooling the NDCs by molecule or by drug makes sense. But the another thing that I think would be really helpful, and I guess my question is if this will be on the dashboard, would be if we could see indication sort of as part of this table as well as we're considering the list. Just like a sort of another point of information.
That's a great suggestion.
And so just a point of clarification, are you looking for indication as by FDA label, by compendia? There are many different ways to think about indication. Is there like a preference that you would want to see for us to use as a data source for, identifying indications?
I guess I'd like to see most common indication, or a list of all indications. The data source, I don't have a preference on that. Really for me as because I'm not a pharmacist, I just want to understand, what these drugs are for. Hung read this list and he knows what they all are right away. And so, but I need a little guidance to understand, what the drugs are, who's using them.
That makes sense, Doug, because it's oncolytics, biologics, MS drugs. So it'll be nice to break it down. Kelly, would you be able to have a separate list that is non-specialty? Like I know the specialty list is kind of iffy because the definition of specialty drug changes often, like price and but if you can have something that may not consider specialty, it might help us look at the list and how we decide.
And Kelly, I can help you pull out the specialty versus traditional. So we do have those lists internally that we can use. And then I also have an idea for how we can pull out indication based off of what we use internally for drug reviews. So I think those 2 things we'll take back and work on.
How would you define specialty in this case?
So for us on Apple Health, we do have a flag on our Apple Health PDL, which is whether a drug is considered specialty or not. We also have another data source for Uniform Medical Plan, so that's the state self-funded health plan for public and school employees. And our specialty list is determined on what is eligible through our contract specialty pharmacy. We have two different lists that we
Okay.
can look at and then kind of use as a general guide to see what drugs fall into these lists. So we're gonna take a look at both and propose one as kind of an option going forward.
Okay. That sounds good. Yeah, I know CMS has a specialty definition as well, which is basically just based on the cost of the drug. But I assume I think the Washington definition would be better for our purposes. So
And we've blended PEP, SEP, retiree and non-retiree,
Yes.
so it's all.
Yeah, so it's all
Yeah.
through UMP, so it doesn't matter kind of covered life, it's all through that. Yep.
Okay, so Kelly and Jingping, does that sound doable? And I guess kind of internally, would we need additional approvals to add that data to the dashboard?
Yeah, I'll work with Ryan to see like where we get the indication data from, and then yeah, he can also help with identifying the specialty drugs.
I have another question for Hung. Your motivation for separating specialty and non-specialty, is that just to understand how many people are using these drugs? Is that your main goal?
Yeah, yep. And because that was my first concern, right? When I see this list, I see there's only less than 5% of the population would be
Yeah.
on this. And so whatever we do with these lists, it's not that it only affects such a limited number of folks.
Yeah. And I agree that's definitely an important consideration. That said, if this comes back to the question of like, do you care about a medium high cost for everybody or an exorbitant cost for a few people? And maybe we care about both. So yeah, I guess like I agree with you that having that data in front of us will be helpful. So
Yeah. The other thing too, Doug, is when you talked about criteria and out-of-pocket costs, these drugs are always going to be high out-of-pocket because the tier they're in is not first or second tier. They're in a specialty tier that out-of-pocket will always be high. It's either a percentage of the cost or it's the highest copay you're going to see. So it just self-select all of these just because, and that's one of that's probably a point of discussion that we need to have is when you look at out-of-pocket, it's not determined by the drug company, it's also determined by the insurer. It's what's on formulary, what's not, what's on rebate, what's not. And so it's going to change from one insurer to another depending on your out-of-pocket. So it's really hard to look at the whole when that's a criteria. Just
Yeah.
a point to think about.
thank you. That's helpful.
And I forgot to mention that all 25 of these drugs were on the list for course of treatment costs $60,000 or more. So yeah, that plays into Hun's point that these are like all drugs that cost a lot out of pocket.
Yeah, I mean, just to reveal my motivations, that's what I care most about. I care more about the out-of-pocket costs than I care about plan costs or even if the plan is Medicaid. That's again, I care more about the out-of-pocket costs than I care about costs to taxpayers. So yeah.
I guess I'll push back, Doug, because even if the plan is paying for it, it raises your health insurance costs. So it's still going to come out of everybody's pocket.
Yeah, I think that and I totally appreciate that point, and I agree that like total plan cost is important. But to me, it's just the out-of-pocket. When I think about the burden of these costs to a consumer, to a user, the out-of-pocket captures that more for me than total plan costs. There's a lot of the taxpayer base, in a lot of cases, can afford to pay higher taxes and the pool of insurers can afford to pay higher premiums. But a lot of these out-of-pocket costs, when they're so high, I think that's what really hurts people. That's what really causes excess costs. And so that to me is is my most important goal.
So really for you, it's the affordability to the person, not
Yes.
necessarily to the system.
That's right.
Any other thoughts, comments on this?
Many comments, but we can go on for a long time. So all good points. I mean, it's great. Food for thought.
I guess one of the, just to wrap my head around it, is there like the mission of this group, has anything been kind of written down or agreed upon? Are we more focused on kind of a meld of what's best for the system and saving money overall? Or are we focused more on, you know, shielding individuals from extremely high cost drugs, or sort of just allowing the board to express their own interests and thoughts with regards to what's most important? And that is that the idea of the ranking. There's not a specific target. Yeah.
I
Okay.
mean, it's really the affordability to who.
Yeah. So yeah, we leave that kind of to question.
Yeah,
Right.
So on our website, on the mission, it says affordability to Washington consumers. I don't know if you pull up the law, actually Ryan should probably clarify this, but it just says excess costs, right?
Yeah, so the statute says for prescription drugs chosen for an affordability review, the board must determine whether the prescription drug has led or will lead to excess cost to patients. And excess costs, as defined in statute, is one, the cost of appropriate utilization of a prescription drug that exceeds the therapeutic benefit relative to other alternative treatments, or B, costs of appropriate utilization of a prescription drug that are not sustainable to public and private healthcare systems over a 10-year time frame. So it's both.
Yeah, sounds like both.
But again, as the board, you're able to debate and kind of pick and choose. So you may look at certain drugs that you say, wow, this out-of-pocket cost is really above the norm. Let's have that be eligible for a drug review. And for these other drugs that are not sustainable for the state and private healthcare systems, we can choose those for affordability reviews. And as you go through those affordability reviews, you'll have a better sense of what is causing those drug prices to be where they are, what the therapeutic alternatives are, and then that's where the upper payment limit, step comes in, and you get to kind of do a second review of the drugs with a better understanding of how they're used, what patient assistance there is, how it's being used in the state, and those other criteria.
And one thing I'll say too is, part of this is for the board to decide, where they want to focus, because there's a couple different angles which we can take this. But that being said, we're doing drug reviews every year. So, just because we do something this year doesn't mean this is forever the way it shall be, and we're only going to go down this. So maybe this year we can focus on out-of-pocket costs. Next year, maybe utilization can maybe be a little bit more of a priority. And I'm not saying that's the way it has to be, but all I'm saying is just because we make a decision on a number of drugs today doesn't mean we can't tweak or take a couple different routes and every year maybe switch up stuff a little bit to okay, well, this is our priority next, and then this is our priority next. So maybe just don't get too lost that, oh my gosh, this is the decision we're making and this is forever written in stone and we can't do anything different. I think there's some play where every year we get a new chance to choose, and maybe after we look at something, we can adjust our weights or our rankings a little bit. Again, this isn't policy. This isn't whack. That's a lot harder to change, or legislation that's kind of set.
You never know what the legislature will do to you.
Yeah.
Right.
So yeah, I guess just kind of keep that in mind, that the board, there's some decision points to be made, but there's also a degree of flexibility in that just because we do something today doesn't mean that's the way we have to do it forever more. So.
Okay.
All right, well, I just have a few more slides and then we can go back to discuss the point allocation if we want. All right, so as I mentioned before, after creating the shortlist, the board will look at the weighted rank along with all of the data measures together to select prescription drugs for affordability review. And then now that we showed the preliminary shortlist, we also looked at what other state PDABs were doing in terms of affordability review and see if like anything overlapped with our shortlist. And so only one state, Colorado, was looking at Enbrel, which overlapped with our shortlist. And then I think one of the reasons is that like what Ryan mentioned, like their thresholds might be lower than ours. And then another is probably that we have like our bill says that the drug must be on the market for at least 7 years to qualify for review, while other states may not have that. So there's also a lot of like newer drugs like Ozempic on the lists of other states. And this is just a continuation of that table. All right, and then the next steps for us will be to review the data measures for the prescription drugs on the shortlist. But now that we had our discussion, it'll be to generate another shortlist of the top 25 non-specialty drugs. And then, yeah, we'll select drugs for review from the shortlists, plural. And that's the end of my presentation. So do we want to go back to the points slides, or do we want to, is there any like other things we want to discuss before that?
Can you go back to the last slide? I like the Oregon list. That's just taking a look at it. So they have infusion in here, Ocrevus and Inflectra. And then there's diabetes medication. So those are non-specialty.
Yeah, I know for Oregon statute, they are required to have an insulin every year on their list, which is why you see Tresiba and the Humulins on there. So that's unique to Oregon and why you don't see insulins for any of the other states.
Yeah, Shingrix, interesting.
Yeah,
Another
yeah,
one,
sure.
So vaccine. And then the big one is the Ozempic. So that's people use that for weight loss, as you all know. So but I don't think that's been out for that long. Oh, okay. HIV meds.
Kelly, can you remind us for our short list, what were the years of data that we used to calculate those ranks?
So we used any data up to January 1st, 2023.
What was the start date of the data?
So for the claims from the All Payers Claim Database, we use calendar year 2022 data.
Okay. Thanks. Just one other follow-up. The threshold, if it seems like the threshold is driving major differences in who, which drugs get on the list for each state, we can't touch that, right? That's in the law, right?
Yeah, so in order to do that, we would have to go through agency request legislation and go through a process in which the agency would be working with the legislator to sponsor a bill. So probably the earliest that we would be able to do that would be the next, not this 2025 legislative session, but the second half of the biennium in 2026.
Okay, thanks.
But I think
Yeah.
after you go through this affordability review and you have more experience, that then gives further support to why you would be recommending changes. But again, once you have a bill that's introduced in committee, there are going to be amendments and it, could always change. So that's something to keep in mind.
Yeah, I didn't mean to suggest that we change the threshold. I just wanted to understand like sort of what's within the realm of our current sort of capabilities for for selecting drugs.
Yeah, the only other way around that would be the drugs that have X% increase over a given time frame. So that's kind of the only other option that our current legislation has for us. So.
All right, do we want to go back to discuss the points?
Yeah, I mean, I'll just note that, like, actually, a lot of what we were talking about before is kind of what I was interested in, and I think, as we were discussing the whole trade-off, or I guess not necessarily a trade-off, the issue of affordability to patients or affordability to the system. That is kind of what I wanted to talk about, and and it was very helpful to hear that we do have kind of have the mandate to do both, and so I definitely agree with Eileen's point that the system is also important, and obviously it says so in the law. And so, yeah, I'll just reveal I was board number 1 on this, and so that's why I kind of and you can see my goal here is to affect patient costs, which is why I didn't give any weight to total paid amount. I think total number of people using the drug is very important, but that's captured in total out-of-pocket cost, and so I gave my points there. But yeah, I don't know if anyone else had any other comments on it.
I don't remember mine, but what I know is I'm always leery of the out-of-pocket costs, and just what I said earlier, it's just not determined by the cost of the drug. It's also by insurer. And if this was all cash, then yeah, easy out of pocket. But I think there's just so much more to it. That's why I'm looking at hopefully the total cost, and then from there somehow decrease the out of pocket cost because the total paid has gone down.
Do you mean because we're not, when you say if it was all cash, it'd be different, but do you mean that's because we're not seeing coupons?
It's my worry is, say you lower a drug by $10,000, what the insurer is going to charge the patient is going to be the same copay. Right? So how do we get them to, okay, let's lower the copay? Then it's just will make it very difficult.
Yeah, that's a great point. So I thought we had it isn't it in the law that like any savings that the plan has are supposed to be passed on to the consumer either via out-of-pocket costs or the premium. Is that true?
Yes, so under the use of savings section in our statute, the upper payment limit that is established by the board must be used to reduce costs to consumers, prioritizing the reduction of out-of-pocket costs for prescription drugs. So there is a requirement that if the plans are applying an upper payment limit, that they have to use it entirely, must be used for reducing cost to consumers. So could be used to apply it to the out-of-pocket cost, and then from there to reduce the premiums.
Okay. And I mean, I guess like, and does that mandate have teeth? Like, what's the enforcement mechanism on that?
That each of the health plans that is subject to the upper payment limits has to provide a report to the healthcare authority demonstrating, how they used those savings in the previous calendar year. So yes, there is.
I'm sorry, Ryan, I'm going to interrupt. This is Donna Sullivan. Doug, the answer to your question is we have no ability to enforce that. It's just a voluntary report or mandatory report to the healthcare authority by the payers. But we have no authority to fine them for not following the rules or any of that. The board has no authority to do that either.
But the insurance commissioner's office in rate review would be able to have some influence on that.
I'll leave that up to the lawyers to figure out.
And rate their approval.
So I guess I
You're
guess
not
if,
a
yeah.
insurance commissioner's office.
Yeah, I don't represent the insurance commissioner there, but I could talk to their.
Yeah, we
There
could,
could be some, but maybe not our agency, would be a
Right.
separate state agency, and so that might be an opportunity for partnership with our programs.
I guess if that's the case, the total out of pocket and total paid would be equivalent, right? I mean, you're hoping that it's gonna get filtered. And I hate to say it, trickle down economics. So it's like
we're gonna be see a lot of that.
I mean, I'll reveal that I'm board member number 5, last one to show up, and that was kind of my thought, is that to make maximum impact out of these initiatives, it will be to reduce total cost of the system. Because again, patients are somewhat shielded based on their insurance plan and their coverage. But if you got a really expensive drug that's has really high share cost, yeah, you could have a high out of pocket. So that's why I was thinking, put most of the energy or most of my points into the total out of pocket costs, and then total paid amount would be for the health system. And sort of we can hit these most highest burdensome cost drugs to the health system and return those savings back to the individual patients. But yeah, I agree. My sort of take on this does leave out, if you have a few patients with a relatively high drug cost, those are not really captured within my thoughts.
But our threshold does capture that, Greg. I don't know if like looking at the list that we got, it ended up being relatively rare drugs, and I guess because of the threshold. And so I think I wasn't expecting that, and so that was interesting. Yeah.
Yeah, this is what we see like internally at UW as well. Our high cost drugs are these biologics that are somewhat niche, and they cost a few patients a lot of money, cost the health system a lot of money. And so every year we'll have a few patients that drive a lot of costs, even just a handful of patients that lead costs for the system, which is really interesting.
So when we do get to the final of trying to choose which ones we're gonna do the review, besides the indications, I guess it would be nice to also have, like, on the spreadsheet, what is the out-of-pocket, basically the information that you use, so that we could just look at that on one spreadsheet.
Yeah, and the dashboard is gonna have a lot more of the cost
Stuff,
info
okay.
out there, as well as the other things that you wanted, do they meet multiple thresholds per
Yeah,
the
okay.
legislation, as well as is there a generic to it? And then, of course, as Kelly was saying, then we've also can compare it to the list of drugs that other states are reviewing, as well as kind of an additional criteria of, and obviously Enbrel was done by Colorado, and I believe, looking at my notes, I believe they marked it as unaffordable.
Yeah.
And so I mean, that's another point to consider. And again, the dashboard will show that cost data. You can compare, one drug to another drug, and then also, see that other stuff, like, is there a generic or something like that, which can help drive the decision of ultimately what do we want.
Hey, Mike, can we talk a little bit about the number of people using the drug? That's interesting, right? I mean, that's the dilemma, right? Is do we want to affect the mass, right? If Doug's saying, well, we want to lower costs for consumers. I mean, there are so many drugs out there that affects so many more than the 3% I mentioned, right? Diabetes is a perfect example. Cholesterol or whatever else. That's important, right? I mean, we're supposed to look at the whole, not just a single set, I don't know, subset of usage.
And I think the challenge really is around the criteria for what makes the eligible drug list. So, in looking at the review for what costs $60,000 a year, there's really none of the cholesterol medication, none of the diabetes medication. So I think the challenge is, having to look at, kind of what meets this criteria, and then from there, choosing which of the drugs will have the biggest impact in improving the lives of, Washingtonians.
That's really interesting. There's no diabetes drugs, no cholesterol drugs, no hypertension drugs that meet the eligibility.
That costs $60,000 a year.
Okay, so that's super meaningful. I did not expect that, and that's kind of makes me, I specifically, so you can see, again, I'm person one. I gave 7 points to average out-of-pocket costs because I wanted to make sure that we captured a rare drugs that were very expensive. And then I gave 13 to total, just, wanted to capture the more widely used expensive drugs. But it sounds like nothing widely used is even eligible. I mean, I would it be, I mean, I agree with how we want to see the number of users. I definitely agree with Eileen that on the dashboard, it'll be super helpful to have all the actual numbers for all these things. Is there any chance we could see that right now? See, what is the most common drug that meets the eligibility threshold?
The dashboard just isn't ready right now.
Okay.
I just can't show it until we finalize all the permissions. But we will, once we got the internal workings here done, we'll get that out, and then we can. You'll have plenty of time to take a look at it, and during our next meeting, we can dig into those other ones a lot more.
And so we don't, and even the short list, whatever ranking we have, we don't have to use that ranking, right? Because we have all those the qualitative criteria that we can then use to decide where we want to do the reviews, right?
Yeah. So I mean, it's not like the number one drug on the short list has to be the one you choose. Again, there's other things that you can look at, does it have a generic that goes along with it, or a different alternative. So if it does, hey, maybe there's an affordable other option, and so we'd rather go down. And so, going on that list, you might make it down to number 18 and 23 are the ones you choose. There's nothing saying we have to pick a certain thing, but these are just different ways that we are working to try and give you information on how to choose and shorten that list to, instead of looking at 100 drugs or 200 drugs, getting it down to a more manageable mouthful based on the criteria and the weighting that you thought was important.
Yeah, and this is just a preview of what the list will look like in the dashboard. So you'll have all the information for those 25 drugs, and then all the data measures that were used to select the drugs, as well as the other data measures that people mentioned they were interested in that weren't used to select the drugs, but it'll still be there for you to look at. And then, so this patient liability proportion kind of confirms what Hung said about, the drugs are kind of niche. So you'll have all this information to play with once the dashboard is ready.
That's great.
So Ryan, going back, I just unfortunately know too much about the MS drugs. So the infusions, all the MABs then are considered specialty drugs or they come from a specialty pharmacy, so they're not included?
They could be included. I think the reason that you're not seeing a lot of the newer MABs is that they haven't been on the market for 7 years. Some of the newer MABs, I think.
Yeah, but I'm just surprised because there's the 3 MS drugs that are on the list are all the caps oral.
Right.
I hardly use those.
Yeah, right. I mean, again, this is based off of our review.
Yeah,
so
no,
some of those.
Curious. That's all.
Yeah, and then I think some of the other ones, since they are only available through a physician administered and are never available through a specialty pharmacy, those ones were also excluded. So yeah, there were some of the newer ones that are being used that are not on for that reason.
Just to clarify, Ryan, infusions are not included, right?
Yeah, if it's only available through an infusion and never distributed through a specialty pharmacy, those would have been excluded.
Well, I mean, yeah. there's a discussion in PQAC, right, about white bagging, brown bagging. And so you do have some of these being forced to go through a specialty pharmacy and get sent to a system to infuse. I mean, that technically would touch a specialty pharmacy
Correct.
potentially. So, but
Right.
Okay, what's white bag and brown
Yeah.
bag? That's a new one on me.
oh boy,
I know.
brown bagging is, so if you're talking about a drug that needs to be, say, administered by the physician, right, where you can't take it, brown bagging is the patient bringing in the drug for the physician to inject, which most health system won't allow you, because what if the patient have left it in his or her car at 95
I get
degree temperature for a few hours, right? You can't trust that. White bagging, if it's getting directly shipped to the physician office by a pharmacy or the manufacturer, and so there's a chain of custody, the patient doesn't get to touch it. And then the physician would infuse or give that medication. That's
Oh, you mean the nurse would infuse?
yeah, somebody from the physician office.
Thank you for clarifying.
I just want to make a point here.
So to Hung's point, you know, between the white bagging and the brown bagging, you know, those do relate to our statute, because our statute just says, you know, is the drug available through a specialty pharmacy? And if it is, then it can be included.
That's-
Yeah. So something that we'll need to keep an eye out for as we're doing future eligible drug list reviews, you know, seeing how some of these drugs may change their distribution channels.
Well, yeah. I would think maybe in the future, the statute may want to change just because of how many more infusing, you know, drugs are on the infusion.
Right, I mean, and that is another point, you know, as we're seeing the shift to physician administered, you know,
Right.
provider administered drugs, you know, that might be something the legislature could look at.
So my only other question is, do we want to revise our votes again? I mean, I wouldn't mind changing mine a little bit. I guess I'd like to change mine a little bit, but I don't know if we're what stage we're at and if that's possible for us.
I would say if you want to make changes sooner rather than later is always better. You know, you guys are the board, so you're driving the boat here. But yeah,
I thought it was an airplane.
or airplane. Yep, sorry, my bad. My bad. Keep me on track here. But so yeah, we can do that. It's just a matter of then recalculating the various formulas. So
Okay, I'm gonna send slight changes to mine. So and then obviously everybody can do what they want. So
Kelly Jingping, is that a-okay with you guys on the back end?
Yeah, I wouldn't change it would just change like the input, not any of the calculations.
Okay. Anyone
Give
else?
folks a couple weeks if they want to change or a
I'd
week.
say only a
change
week.
it.
Okay, yeah, as again, sooner rather than later, just so we can finalize this and get it out once we finish the rest of the internal work that we have to do. So
Mike, do you want to set a deadline for us?
oh yeah, sure. How about next Tuesday? Does that sound fine? Okay,
Sounds fine.
great.
Sure, I might change mine too.
Okay,
I have to go back and look at what I did.
okay,
Yeah.
sounds good. Okay, so Simon, let's make a note to do that here.
All right, and just to confirm, we want two shortlists. So one would be like the one we have now, which just happens to be specialty drugs, and then another short list of the non-specialty drugs, right?
Yeah, we can take a look. I'm sorry, Kelly. I know it's more work.
Well, and again, I mean, I think this is part of what our review here is for, is to show you, as we're going along, okay, this is what we got, this is what it's looking like. And again, I think this is, as especially in these early stages of setting stuff up, getting that internal feedback from the board members, from the staff, the external feedback from our partners in industry or other interested groups. It's really important to help us so we can refine this and build a durable product. So once we've got the foundation set, then hopefully the rest of this should be a lot easier in the years that are coming to, okay, we've done a good job of vetting this and testing it and tweaking it to get it to where we want. So yeah, I think that's good. This is why we're here having these conversations. So thank you, board members.
Oh, this was a really good conversation.
Okay, so we'll get that email sent out with the deadline for the updating and adding us the non-specialty drug list, and we can kind of go from there. Hold on, just making some notes of myself here real quick before I forget anything. Okay. Any other thoughts or questions on our weights and the initial list and kind of how we're doing and what things are looking like thus far?
Doesn't look like it.
Okay.
Like we can go on to the next
Okay.
item. So like this one is also yours, the advisory group. We need some to hold for the advisory group.
Yeah.
Turn it over to you.
So as I mentioned earlier, we had our meeting with our advisory group, and as we can see today, we're really getting into kind of the core of what we're looking at, why we're looking at it, what we want to look at it. And then, of course, the advisory group is going to play an important role in terms of giving us some of that external and industry and other feedback from other groups. I guess kind of the next steps for them and the vision was we're going to be having a meeting, I want to say December 10th, right? Is that right, Simon? With the advisory group. And basically we'll introduce them to the dashboard and this content as well so they can take a look and see. And then I think really the important thing is to get their feedback on that so that way we can gather that information per the legislation to help the board make decisions as well. So, so for the next meeting, the idea is introduce them to the dashboard because should be ready by then. So that way they can take a look. They can start looking at this initial list of drugs, and I'm open to ideas or suggestions. But my thought was. Basically task the advisory board members to each, using the list that we have, pick a certain number of drugs that they would recommend that they think are important for us to take a look at, and maybe an explanation as to why, and some of their thoughts in terms of the list and I guess the conversation that we've had in terms of ranking and what they feel is important. And then each of them have submit their list so that way we can give it to the board before the meeting to review. And you can see, I guess, what the advisory board thinks about the dashboard, the drugs on that list, and kind of their direction in terms of the kinds of drugs that we should be choosing. So, and I don't know, I was thinking a list of maybe 3 to 5 drugs from each of the advisory board members to help kind of point the way of what they feel is important. So open to ideas or suggestions on what the board would like to see in terms of feedback from the advisory.
That's good. I think 3 to 5, that's good.
I'd like to see at least 5.
Okay.
Yeah.
Will you send us the dashboard as soon as it's done?
Yes. Yep.
Okay.
Yeah, no, and again, we're trying to, there's internal workings that,
No, I'm just.
at the speed of government.
Yeah. As soon as we can see it, it would be nice.
Yeah, and that's the goal is we're trying to get that out here much sooner rather than later. Then we can.
A Christmas present.
Yeah. Well, hopefully an early Thanksgiving.
Oh,
present,
goodness, you're really being, you're very.
So yeah, and so yeah, that way both you and the advisory board can have some time to take a look at this, and then hopefully during our advisory board meeting have a nice robust discussion as well in terms of what they think and then again, providing if each of the members could provide a list of, I think you said at least 5 recommendations with reasonings. So that way the board can take that input as well. And we can discuss it in our next meeting. And Doug?
Yeah, I was just wondering, that also, I totally agree about the recommending drugs. It sounds great. A question about like our role at the advisory board meetings. Are we just like observers or members of the public? Are we expected to participate? What's what's the plan for that?
So yeah, the general purpose is the advisory board is to advise you. So again, getting some of that other outside input and then pushing it up our way. That being said, you guys are definitely welcome to attend. I believe there's not a problem for a degree of participation as well, should you desire. However, the thing that we have to really watch and be careful is no making decisions as a board, because then that changes the whole, when you guys start working together and making a decision or starting to do stuff, that changes the whole meeting from an advisory board meeting to an open public board meeting, basically, which then we've got to have this kind of a setup, and it's a whole different thing. So I think care and limited participation are important with that one. And again, that's more for I guess my vision is the advisory group working together to get their external group perspectives and then bringing that up to you via how we decide with for example this report of them giving their recommendations.
Well, I mean, it might be interesting too to listen in from their perspective, the conversation and their how they see the world.
Yeah, no, and I think definitely that is very good. Listening and seeing what they have to say, and again, I think just careful participation and making sure that we don't cross any lines in terms of decision making or trying to influence policies outside of this meeting.
There to listen primarily. So will you send us the times? Okay.
Yep, definitely do that.
And is that in person or online?
It's online. So that one's all virtual.
All online.
Just because of the the range and how spread out.
Yeah.
So
that makes sense.
Yeah, makes it a lot more conducive for that group.
Mike, your comment about the the PDAB members can't talk about PDAB business outside PDAB meetings reminded me, what is is it we have 3 people then we can't talk about it, but if there's 2 people we can? Is that the rule?
Should be right.
Mr. Lawyer?
Well, yeah, 3 would make a quorum.
Okay.
Yeah, and then, so the other thing though, there's I think I've heard it called like daisy chains, but yes, you don't want, sort of, Doug to talk to,
So in a sense, if there's, So if 3 of us happen to attend an advisory board meeting, we basically can't talk because all we're going to be talking about is PDAB business.
Yeah, so the Open Public Meeting Act says, you can't, be taking any type of action. So it's best to, not talk, with each other, because then, even if you start not talking about action as the conversation goes, it can then spill over into action. So the best, advice is just to, not talk about it with others outside of the open public meetings.
But we could all be on as not panelists.
Oh, yeah.
Then you're,
Easily, yeah.
Because you're not talking to each other, so then you don't have that risk of by accidentally taking action.
Yeah, so like if your kids or grandkids are all in the same like little league team, you can attend the game and talk about that, but you don't want to like then cross and start talking about PDAB business. But yeah, go to non whatever functions together, but not
like the governor's ball.
Yeah.
There you go.
Yeah.
I haven't received my invite yet, but yeah.
Any other questions on the advisory group and kind of expectations or hopes from them?
No, I think it'll be really interesting to listen to their meetings and just get a sense of what they have to say and how that might influence some of the decisions that we make here.
Perfect.
Certainly.
Okey doke.
So are we ready for public comment?
As I say, we're making fantastic
Yeah, we
time
are.
today.
Yeah, really. Making a lot of progress.
The weather's even cleared up, it looks like,
Oh,
so, I mean,
Go out.
this is, we're winning on all accounts
Storm.
right now.
Would you not say? Click on public.
Anyone signed up?
Yes, we had one person sign up in advance, which is Daria McGrew, who's also a member of the advisory group. And then it looks like Ronnie Shore has also raised his hand. So we can start with them, and I'll open it up and see if anybody else raises their hand. All right, feel free to jump in.
My turn. Thanks. Confirming you can hear me?
Yes.
Yep.
Thank you, Chair and members. Daria McGrew, Director of State Policy for Pharma. I really appreciate the board and staff for the detailed discussion today, really important topics. We will submit more detailed comments after we've had a chance to fully review the materials. I want to first point out that the board has some mandatory and some additional criteria for choosing drugs to review, and note that this preliminary subset, you have not yet considered all the mandatory criteria set out in statute. So Pharma would urge you not to go too far ahead into choosing drugs for review until you have had a chance to consider all the mandatory criteria at a minimum. On a small technical note, if the board is interested in further comparisons with other states, I would respectfully suggest that the board staff go back and take another look at the Oregon list you've provided. Several of those drugs were subsequently found to be ineligible for review due to errors in data analysis. So this highlights the difficulty that many states are having in evaluating the data and the need to proceed in a very clear and careful manner before going forward and then having to make corrections down the road. The biggest issue that jumps out at me from the discussion today and the new policy is the reliance on APCD data and using the total paid amount, since it is not net of rebates. I'm sure that the board is aware, but I think it definitely needs to be stressed and transparent. Since total price paid was ranked fairly highly by the board's point allocation. Unfortunately, prices paid in the pharmacy claims are not reflective of the net price or the actual price paid by plans and payers. Furthermore, the APCD data skews costs upwards due to hospital markups on drugs. And this may also have some bearing on the discussion today about the prevalence of specialty drugs on the preliminary list. Looking at patient out-of-pocket costs surely gives you a metric of patient affordability, and I appreciate the recognition that out-of-pocket costs are determined by the plans and the PBMs. But many of the drugs in your preliminary subset list are likely highly rebatable drugs. So I recognize that the proposed framework for affordability review would look to quantify net costs in the next step, but I ask that the board recognize that the subset list from the ranking exercise is based on some of the criteria are artificial prices that are not reflective of the real drug costs to the payers. Thank you.
Very much.
Thank you.
And I had seen Ronnie, you had raised your hand. Would you like to make
And my name is Ronnie Shore. I'm a retired pharmacist who is on the advisory group, and I would just support the decisions to choose drugs on the values that you put forth. There is no way we can cover all of the issues that are determine the price by some beginning rankings like this, but looking at the cost really does address the pharmaceutical manufacturers end of it. But considering out-of-patient pocket costs is more than just a patronizing comment to the public. That considers the other big factor, which is the insurance company and pharmacy benefit managers that impacts the drug costs. I think Dario would agree with us that the cost we're looking at is not just from the pharmaceutical manufacturers. So choosing these two factors is good. As we go along, I think we'll look at some of the other mandated adjustments, whether prices have increased. And Doug probably could lead us in the discussions on the other impact of the drug, whether we need to determine whether it really improves our lives, quality of life years, or there's a dozen ways of looking at life years. So hopefully we can use those economic basis to help with that decision as we go along. But the factors you've discussed are the perfect context to begin this analysis. So thank you.
Thank you.
Thank you very much. Any other comments?
I don't see any other hands raised on the Zoom. I don't know if anyone in the room has comments.
We have the meeting set for.
Yeah, what are our next meeting on the calendar? We got January. Looks like the 15th.
I thought you sent out 25.
I've got 15th, Jan 15th.
Yeah.
Maybe you could resend it. I thought.
Yeah, I was gonna say, look, maybe, yeah, we can resend out the schedule. I know we talked about it, we planned it.
It's not on the list that came out from the Healthcare Authority about that with the other ones, like with the Healthcare Cost Transparency Board and their advisory
From
groups.
the registrar?
Yeah, I didn't,
Okay.
at least it was one that I got this week.
Okay. We've got the road reserved. Okay.
Yeah. We'll see with the code advisor.
Yeah, I don't know. Who knows? I'm on the transparency board too, so maybe that's a separate one, but it had.
I mean, it could be, I mean, but they do both have to go through the code revisers.
Yeah.
They are OPMA, but it looks like we have them scheduled for the third Wednesday of the odd months. But yeah, we can just double check to make sure that that was posted.
Hold all day, right?
Yeah. Yeah, between the advisory board input and us reviewing the dashboard, bulk of the meeting in January is gonna be figuring out what drugs we wanna look at, so. It should be a fun one. Okay.
Meeting adjourned.
Okay,
Thank you.
thank you.
Thank you.
All right. Thanks, everyone. Have a great day.
Good to see y'all.